I think we can start, right? Hello, everyone. Good afternoon. Yeah. How is it so far? That's great. So, welcome, everyone. Uh, my name is Brikti. I'm from Ethiopia, Ministry of Health Ethiopia, and welcome to the ICFP. And today's presentation is about innovative data source to improve monitoring and decision making. So without further ado, we don't have a lot of time. We have four presenters, and I'll go straight to them. So our first presenter is Daniel Ressar. She's a manager in HIV prevention at the Clinton Health Access Initiative. Her work includes a focus on family planning for new product introduction, including novel multi-purpose prevention technologies that combine HIV prevention and contraception to better meet the sexual and reproductive health needs of a woman. In addition to the new product introduction, she is passionate about supporting the integration between HIV and sexual and reproductive health. So, and also strengthening health systems, including M&E systems, and to enable the integration of the services. So you can take the floor, Daniel. Thank you.
Um, Thank you so much for having me. And good afternoon, everyone. Let me just make sure I can touch my screen. Great. So thank you so much for having me. Today I'm very pleased to present Dual or Dueling, a review of HIV and family planning M&E systems to inform introduction of multi-purpose prevention technologies on behalf of the team of authors listed here. So to get us started with a quick knowledge check, raise your hand if you are familiar with a dual prevention pill or DPP. All right, a few, great. So today we'll be covering a range of topics, starting with some background on what multi-purpose prevention technologies are and what the dual prevention pill is. So if you didn't raise your hand, you're in a great place to learn. And then we'll be getting into the meat of the analysis on monitoring and evaluation and what system changes are needed for MPTs based on existing HIV prevention and family planning M&E systems. So I will get started with a little bit of background. To answer the question of what the dual prevention pill is, it combines TDF-FTC with LNG-EE for contraception into a single pill to provide dual protection from HIV acquisition and unintended pregnancies. So partners are also working on an FTAF-based DPP, which is just a different formulation of oral PrEP, but the same concept as I have here. So it's 21 days of a combined product. So that product integrates the combined oral contraceptive and oral PrEP. And then 1 week, which corresponds to the contraceptive placebo week, would be just oral PrEP. So there are a few potential benefits of this kind of product for end users. Overall, as we have seen in other disease areas, simplifying regimens to a single pill formulation is often preferred. So if we imagine people who may already be taking oral PrEP and oral contraception, we can think of this as a simplified single pill regimen. Further, we also know that people prioritize pregnancy prevention and HIV prevention differently. So what that means is the dual prevention pill may provide another option for providing an additional layer of protection to what someone is already prioritizing or taking. And then finally, from end users, we know that from the HIV prevention perspective, an option that has added pregnancy protection is highly preferred compared to a single indication HIV product. We know less about what those preferences look from the family planning perspective, so that's an area for further research. So in addition to those end user advantages, the DPP will provide an opportunity to drive integration in health systems and gain experience for policymakers and really the global health community as we have more multi-purpose prevention technologies in the pipeline that I'll get to in a second. So the focus of this analysis is really to take a holistic view of what changes M&E systems will be needed to effectively monitor MPT introduction and delivery. So Again, as I had noted, there is a diverse pipeline of MPT products in early stages of development, in addition to the dual prevention pill, which is currently in bioequivalence studies and could be submitted for US FDA approval as early as 2023 if these studies are successful. So what that means is strengthening and adapting M&E systems for the DPP will be critical for efficiently introducing these later stage MPTs, and also important just for planning for the integration of contraceptive service delivery with novel and existing HIV prevention products. Throughout this conference, we've heard a theme of kind of person-centered care and making sure we're meeting women and users with all the health needs they have. So for this analysis, we've been looking at M&E systems from a holistic perspective, so incorporating a few lenses that I've shown on this screen. So on the left, we're considering the different time periods during a product's introduction pathway. So with a new product and really a new genre of product, which many of these MPTs represent, we know there's going to be significant evidence needs in the beginning, so it'll be important to consider that enhanced, often partner-led M&E mechanisms, as well as the longer-term, sustainable, routine M&E systems. And then to the right, just pulled out a view of some of the different stakeholders we considered in this analysis. And all of these stakeholders will have different M&E needs, so governments, communities, providers, donors. So for the last bit of framing, to understand needs for the DPP, we reviewed M&E systems in HIV prevention and family planning, as I said. So for some context when we're assessing those systems, which I'll go through in a moment, it's important to understand their broader history and their context, which we've highlighted on this slide. So one overarching theme that you may pick out already is that family planning M&E is much older and more mature, so they've had a lot more time to iron out some of the challenges that we're currently seeing in HIV prevention. So that's kind of consistent across a few items here, but for one, in terms of method mix, in family planning, there's really already a lot of experience, whereas in HIV prevention, we're just starting to look at what a multi-product menu means. And of course, there is significant unmet need in both areas. In HIV, there were more new infections in 2021 than there were number of people who initiated oral PrEP. So there's an enormous unmet need, and in sub-Saharan Africa, where we still see the highest numbers of new infections, we also see that women and girls are disproportionately affected. So some of the same groups who may have unmet need for family planning. So now to look at methods for this analysis. This involved iterative phases of desk review, analysis, and consultation, really aimed at gathering insights from family planning, HIV prevention, and M&E experts from a range of different organizations. And we looked at M&E systems, again, to take kind of a holistic view of M&E. So we used this framework shown on the left, adapted from USAID Measure. And the 6 elements that we looked at are data availability, methods, indicators and measures, personnel and training, data utilization and knowledge management, and sustainability. So we mapped the strengths and weaknesses across both HIV prevention and family planning across these 6 elements to inform preliminary insights for adapting M&E systems for MPTs. So to identify those strengths and weaknesses, we reviewed a wide range of literature across the 3 countries where other advanced planning for DPP introduction is currently taking place. So that's Zimbabwe, Kenya, and South Africa, as well as global guidance, databases, tools, reports, and published literature. So now I'll bring us through just a few highlights of this analysis. So starting with just a snapshot view of some of the indicators included in the PrEP M&E framework in Kenya as of 2021. These cover the HIV prevention cascade, but there is variable data quality across these indicators. For one, because we've seen that people tend to cycle on and off PrEP according to when they're at risk of HIV, it's particularly challenging to understand how long people are on PrEP and whether they're actually using it effectively over periods of risk. And then if we look outside of routine systems to the right, there are a number of HIV surveys and indicators integrated into various demographic surveys, but we have not yet really seen that for PrEP. So then looking into some of the strengths and weaknesses, I'm just going to focus in on a few areas. So first, for methods, we do have a lot of quantitative and qualitative data from various implementation projects and studies with rigorous scientific methods. So these have been really valuable in understanding the nuances of continuation, reasons for discontinuation, barriers to care in those focus studies. And at the same time, there is an increasing focus on simplifying M&E methods to get that balance of needed data without overburdening providers. However, there is a lack of systematic evaluation for PrEP programs, and there really is a high prevalence of paper-based data collection, which causes inefficiencies in the process. And then looking down at indicators for PrEP, we do have follow-up visits tracked in some contexts, which does provide some view on continuation. We also have increasing coordination of indicators across countries, including some supply-side indicators, but indicators are still not quite consistent across all partners and programs. We also see indicators evolving as we learn more. So for example, PEPFAR just redefined their indicator for continuation. So we really don't have that kind of validated set of indicators that we see on the family planning side. Another challenge is, as I had alluded to before, really challenges measuring effective use since we learned that people tend to cycle on and off PrEP according to their risk. So a measure like continuation may not be the best measure of success. And then finally, unlike family planning, where we have relatively strong unmet need measures, this is also an area that's lacking on the HIV prevention side. So now just jumping over to highlight another quick view just for the family planning perspective. We see the really well-validated, flexible couple-year protection rate within DHIS in South Africa, just looking at a different country snapshot view. And then really to highlight on the right side, really strong data initiatives across countries for family planning M&E. So looking at some of the strengths and weaknesses, as noted, we have really strong databases of well-validated indicators, and this is important because, again, this is not something that we see on the HIV prevention side, where that validation is still ongoing. We also have timely inclusion of new indicators for new products. So, for example, with couple years protection itself is a great indicator for consolidating data across different products with product-specific conversion factors. And then on the other hand, there may be an over-reliance on indicators like couple years of protection, which is easy to collect, but ultimately reflects distribution, so does not capture actual use or impact, choice, client satisfaction. Lacking on some of the nuances of some of those potential indicators. And then finally, just to do another quick highlight for family planning, on sustainability, again, family planning M&E looks really strong with integration into national health information systems, which we do not see yet in HIV prevention. But where those systems are insufficiently resourced themselves, we still see some challenges, even if that integration is there. So now to quickly kind of wrap us up, to look at insights for MPTs, and again, just look at some of the examples we saw before. So looking at, again, kind of two periods, thinking about evidence needs and implementation projects, and then kind of moving into early introduction. Starting with methods, looking at implementation projects, based on the novel nature of the DPP and all the questions around adherence, use in the context of more effective contraceptive methods, we know that these projects will need to leverage more resource-intensive M&E methods than are feasible in routine systems. So in doing so, early and ongoing sensitization to align on expectations for what methods are feasible to use and what data will be available in routine monitoring will be quite important. And then for early introduction, it'll be important to leverage the methods used in both family planning and HIV prevention, so we're able to compare across major data sources. So, for example, family planning indicators are well integrated into demographic health surveys, which provide a really useful view of method mix over time. And because we'll also want to understand the role of MPTs in method mix, it'll be important to ensure that we're leveraging those platforms and surveys. So for indicators, indicator selection for early implementation projects should be informed by national evidence needs and priorities. And particularly, again, consider those areas that may not be feasibly measured in routine systems, but stakeholders want evidence on to inform introduction approaches. And then as we move into early introduction, shifting from an enhanced monitoring approach, we'll also need to prioritize identification of a minimum set of indicators to validate and then integrate rapidly into national M&E systems as early as possible. So to kind of mirror those well-integrated indicators that we see in the family planning space that we still have not yet achieved in HIV prevention. So for sustainability, I think this one kind of I've heard of many times in the room. And I think folks are familiar with, but we really need to think about making sure that there's early collaboration and knowledge sharing between those partner-led mechanisms and governments, even when the main M&E mechanisms are partner-led. And then as we think about early introduction, the sustainability piece to highlight again is that we do have a strong portfolio of MPT products in the pipeline. So we need to be thinking about some of the efficient, sustainable processes for integrating new products. So now just to conclude, I hope that you found this analysis useful and illuminating of some of the intricacies that we need to think about when we think about introducing MPTs. But one really important piece to highlight is that this is a cross-country analysis, and I've highlighted some shared insights across countries, but we know a lot of the next steps and deeper dive investigations will have to happen at country level. Countries will have unique priorities for evidence generation, unique definitions of what success looks like for the DPP, and therefore unique system changes for monitoring and evaluation of multi-purpose prevention technologies. So just to conclude with another poll to maybe gather some early data on that point, I'd like you to raise your hand and lift up a finger to indicate the readiness of your country's M&E systems for MPTs. So a 1 would be massive changes needed, and a 5 would be pretty well prepared. Those challenges seem like they could be pretty seamlessly addressed in M&E systems. Any initial thoughts to that poll? I saw a 5 for pretty well prepared, so maybe we need to dig into discussion and share some learnings, and I see a 1. Well, thank you so much for your time, and I'd also like to thank the Children's Investment Fund Foundation for funding this work, as well as wider input from the DPP Consortium and the many partners that fed into the analysis. Thank you.
Thank you very much, Daniel. That was a great presentation and a brief one. So we'll go to our second presenter. Our second presenter is going to be Dr. Suzanne Antri. So she's a Senior Technical Advisor, Research and Learning at PSI. She's currently working on the Safe Funded Delivery Innovation in Self-Care that is being implemented in Uganda, Nigeria, and has recently scaled up to Malawi as the research and evidence lead. So she has over 10 years of experience implementing family planning projects in sub-Saharan Africa and currently serves as one of the FP 2030 Measurement and Evidence Working Group. So working group member. She holds an MPH in epidemiology and PhD in global health from University of Georgia in Netherlands.
Thank you, Barky. This afternoon, I'm going to give you more details or share our experiences using AI in collecting data to inform our programming. Delivery Innovation in Self-Care, DISC, is a project that is funded by the Children Investment Fund Foundation and was recently introduced in Uganda and Nigeria in 2020, a 5-year grant, but last month, we actually moved into Malawi with Bill and Melinda Gates Foundation. And the whole essence of Project DISC is basically to scale up uptake of DMPASC, subcutaneous DMPASC, specifically self-injection, by increasing awareness and uptake among those in need. So what is the whole essence of monitoring? Self-inject is a new contraceptive method that was introduced around 2014 in several sub-Saharan Africa countries. And what we know about new product introduction, you actually need a robust monitoring system to help track the rollout. You basically need to invest in social and behavior change to create demand and also service delivery. And to do that, we integrated four, I'll call them traditional data collection approaches, household surveys that were meant to help us understand the coverage, specifically looking at the level of SI awareness among women of reproductive age, client exit interviews to understand the experience of care among women seeking contraceptive methods, specifically DMPAC, both self-inject and provider administered. We also did include provider surveys to look at the perspective of providers on service provision and routine service statistics that basically use health management information system to monitor uptake, or rather indicators such as SI visits. What we realized, these traditional data collection approaches were not sufficient because these are our consumers. In Project DISC, our early adapter segment is basically women, young women aged 18 to 24, residing in urban areas. So we are having women, young women with no children, both new or current contraceptive users, urban young women who are also mothers, and urban adult women aged 25 to 34. So when you look at this segment, it's basically young women who are youth between ages 18 and 34 years. And one of the major route of information is actually leveraging on the digital channel, basically creating awareness through social media platforms such as Facebook, Instagram. And what these informed us was our traditional data collection approaches, whereas they have beneficial in informing us what is happening at population level, they were not that helpful in telling us how best our demand generation activities, specifically our campaign, which is called the Discover Your Power campaign, is reaching the intended audience. So what exactly did we do? When you look at this consumer ecosystem, we are tracking the user journey right from awareness. This is when the young woman is aware of self-inject, and they are aware through the below-the-line activation events. The below-the-line activations are the community events that happen at community level, and the above-the-line, the mass media, radio, television, and mostly, again, as I've mentioned, the social media, where we have Facebook, Twitter, Instagram, Google, and even SMS and WhatsApp. Once they get this information, they end up making a decision on whether this is something that's going to be of interest to them and whether they actually want to take up this method. They are linked up to a chatbot, and following this linkage, they are able to get more personalized information that is very context-specific, where they are also able to be linked to services. We've partnered with a number of organizations that have service outlets in these countries, and following these, we also track continuation, whether they are able to actually continue using their contraception. One of the key elements is once they walk through this journey, what we've seen is based on their user experience, they end up being advocates and are able to actually bring more women into using these. And for our social media, which will be the focus of my presentation, we actually work with the macro and nano influencers in this campaign. So the nano influencers, these are basically people like you and I who are not necessarily celebrities. They just have, let's say, in social media, they may have around 1,000 to 10,000 followers. And they basically post their own content. And because of the content, they end up having quite a number of followers. And we partnered with AI Influence. AI Influence is one of the leading influencer networks in Africa that is able to track marketing in terms of social media to help you understand the level of impression you're having, campaign impression through social media, and the reach. And this is an example of one of the I know the font is small, but this is in Twitter, where you see one of the nano influencers just posting something on self-care, and you can see the level of interaction that is happening. And we have this in Facebook, Instagram, and Twitter. And as mentioned, we realized that we needed to actually utilize artificial intelligence to help us gather data on whether the campaign, whether the influencers are able to reach the target audience. So how did we approach this? We developed an online survey to help us get a pulse on the performance of our digital campaign. And this happened 6 months after implementation. And we did roll this out early last year. And what we did was this was never meant to replace the other measurement approaches that I earlier talked about. It was basically to give us a snapshot of what is happening along the digital ecosystem. And the methodology was we got AI Influence, who was able to push this survey using the nano influencers. They posted the links to the survey in their social media outlets to basically generate responses. At this juncture, let me ask, who has ever responded to a survey in a social media outlet? You know those pop-ups that say, click here to respond? Yeah, sometimes I know we tend to disregard that, or maybe you consider them as nuisance, but in this increasingly era where we've incorporated digital media and social media in our programming, we use such channels to actually collect additional information that can help inform programming of certain activities. So what we did was to come up with 10 self-administered questionnaire on DMPS self-inject, and they range from awareness of DMPSC to know whether the level of awareness, to know whether there was interest, how many of those women who had interacted with, DMPSC, including our Discover Your Power campaign, were interested in taking up this method. And the beauty of, again, using this and the AI influence is because you are able to target a certain geography. Because in as much as we were working in Uganda and Nigeria for this work, we were not covering the entire district. And through AI influence, they were able to literally target, geolocate women who are residing in certain, hotspots where we were using them as because as I'd mentioned, our interventions were not just the demand generation, we also had the below the line activations, basically our road, social media, mass media events, and also the facilities. So these surveys were, they were routed to women who are residing in those subnational levels. And one other thing also to note is we didn't have a control experience, or rather a control group, because again, social media has no boundaries. The other thing also to do, which made this process very interesting and easier for us, was the fact that we were using influencers who had been trained on the SI content as our enumerators to basically, again, use their platform to ask this question. The only thing we did was to provide some incentives to the influencers and also get some level of some targets in terms of the numbers. And all this activity happened in October of last year. So in terms of our results, I won't go into the results of the actual survey finding because this was a methodological presentation. We engaged 40 influencers, 20 in each country. Our initial sample size was around 968 in Nigeria and slightly over 1,000 in Uganda. And within a week, we were able to achieve a response rate of 64% in Nigeria and 61% in Uganda. For those who've been in the digital space, this is a very high response rate from getting just feedback from online users. Again, one of the things we also noted was the sample was comprised of younger women who were also within our age group, which also talks about, the younger women are more likely to be found in social media compared to older women. When we looked at the period that it took right from, conceptualizing of this development of the tools, fielding it, and even getting the initial set of analysis, we were able to turn around this within 4 weeks basically a month. And that fast turnaround also helped us to basically use the insights gathered to further improve our programming. The other thing that we also noted was the average cost per user was less than $5, which is quite cheaper when you compare with the, the household surveys that we mostly rely on. So I'll have these two next slides to basically just show you some of the indicators. This is one slide that looks at, one of the questions was, how likely are you to use self-injection as a contraception method in the future to elicit intent in SI use? And these results are from Uganda. So when you look at this graph, what we basically see is the online respondents who had been exposed to our Discover Your Power campaign were significantly more likely to see SI as a potential contraceptive meal that they will use 83% compared to the 49%, which again informed us that online or digital can basically be one source of information. Again, the other thing that we also saw in terms of, again, awareness, we had a question on, have you ever heard of an injectable contraceptive that you can inject yourself? Those who could recall the Discover Your Power campaign, again, were actually more likely to be aware of SI, 82% compared to 55%. So what did we learn from this experience? First of all, there are limitations to this approach, just like there are any other limitations to any data collection approach. One, the sample is not representative, but it was never meant to be representative because you are basically targeting the audience that you want to reach using your digital media campaign. There is also the self-selection bias. Someone will decide whether they want to respond to the, survey or not. And the fact that we never provided any incentives to the respondents also may have created some low response, though we still feel the over 60% we got was good enough to inform programming. Again, the fact that it's only we basically included, because of the channel, only respondents who are literate, locking out those who are not literate. But again, looking at the project disc, digital is just one media of passing information. Again, the other thing also is because this was again a digital survey, only responded who had access to smartphone were able to access. But one of the things that we found out was that the fact that we were able to turn around this entire process within 4 months. For those who've been planning surveys, surveys take months. I think PMA is one of the new innovations where we actually seen a faster turnaround of within 6 weeks. But traditionally, we know by the time you start planning surveys, get the full IRB protocol, administer, sometimes it takes even 6 months to just get results. And in a fast evolving world where we are having digital campaigns, you need frequent measures to help you inform your programming. And that's what happened with this. The other thing is it was such an efficient and cost-effective approach that we decided to embed it to be part of our quarterly monitoring, to basically monitor how the influencers that we are engaging with are working on. And then the other thing is when we started doing our digital campaign, we had never thought that the influencers could also be converted to be enumerators. We just thought these are influencers that we could engage to pass content, but we've also realized that they can also be a very useful approach in monitoring and evaluation. So our takeaway home is when you have the combined approach of recruiting both enumeration team who can help you deliver your content, that is the AI influencers, and also collect feedback on your digital campaign. That information can be very, very useful in informing any digital programming that you may include. If you want to know more information about Project DISC, you can access it through this card. Thank you.
Thank you very much, Dr. Suzanne. Did you get it? I think they need to scan the QR code again. You did? Yeah. Yeah. Okay. Yeah. Yeah, I'll give it. I think you're done. Is it not working? Yeah, okay. So thank you. So we'll go to our next presenter. Our next presenter is Dr. Daniel Mumbai. Daniel is an M&E officer for Track 20, implemented by Avenue Health, funded by BMJF, and he's based in Nairobi, Kenya, seconded in the Ministry of Health Division of Health Informatics. So his presentation is about Track 20 family planning module, building family planning environment within the national HMIS to support the data used for M&E and decision making. So I think some of you may have questions, and we will have a Q&A at the end of the session. So be patient until then. Thank you.
Okay, thank you. Today I've been going to present to us about a digital solution in form of a dashboard called the FP module, built within countries' health information systems to support data use, monitoring, and decision making for countries, partners, and all users within the family planning space. So the family planning module is built based on a series of steps or work that has been ongoing. We first started by digitizing our estimated modern use indicator. Then we end up to expand that to cover across family planning. And then we had this installed in the national HMIS, that's DHS2. So we have done this with collaboration with Dura Technologies, who have been working on developing innovative solutions for within the public health space. So the module sits within our DHS2, or what we call the HMIS, across various countries, and is designed to adapt to what are the user needs for respective countries. So what was the purpose, or what was the goal for this work? So the goal was to be able to have a solution that is sustainable. That's the first thing. The first thing we did is that we implemented this within the DHS2 environment for each user country. So it's hosted by the countries and owned by the user countries, so that in future they don't need us for any issues. So they're able to monitor it, install new versions, and control. So it's within the data infrastructure for the countries, HMIS. Also, wanted to expand the use of service statistics data. So basically building the culture of data use across countries, so that they're able to look at their data on a frequent, way, now that surveys are only being done on an annual basis. We also wanted to improve the quality of FP service statistics. So as most countries or systems turn into utilizing the service statistics data, as we saw for the case during the COVID-19 pandemic, whereby you want to look at the data to understand what has been changes, volatilities, what has been growth, what has been some of the vulnerability. So we want to ensure that whatever you're using is of reliable and of quality. So the solution has a component that is able to help you flag out issues of quality and address at a click of a button. And lastly, wanted to also to expand access to quality analysis. at both the higher level, that's within national ministries, programs, but also at the upstream level. That's where we're having generation of data. So that's at the facility level, so that they are also able to generate data and also use it at that lower level. So that was all the call for this. And within the application, we had some capabilities to ensure this goal is achieved by having a solution that has a robust admin functionality to assign various user roles, a solution that minimizes data to create new indicators, so we're able to scale, is scalable. That's one of the beauties. So it's scalable, even as you shall see, during the various user experiences we have done, there's high demand to scale to have these to cover aspect of maternal and child health indicators. So, and also has a component for data review and also standardized results available at all levels. So these are some of the country implementation for this solution. So far, we have the solution implemented in Kenya. That's where I come from. We also have in Zimbabwe, in DRC, Congo. We have India, Nigeria, and also discussions ongoing to have this scaled. Also in Uganda, we have been having discussion and implementation in progress. So these are various user scenarios or country where we're having this solution implemented. So this is how the FP module looks. As you can be able to see, what we have there are the 6 components. So the key 6 components, we have the summary dashboard. We have another component called the analytical dashboard. I also talked about data in terms of them able to collect issues of data. We have the data quality review. We have map visualization, interactive analytics, and also saved favorites. And just to mention that for the summary dashboard is tailored towards having the program managers or those sitting at a bit higher level, even at the county level, going into the solution or into the HMIS and defining various dimensions like the location they want to see for this data, the time dimension, and the period and being able to just download a presentation on key high-level indicators on family planning performance. And this has been very instrumental for reproductive health coordinators for the case of Kenya, where they only relied on IT or health record officers to generate data for them. So that is tailored for having a quick view of or a quick summary on key indicators for family planning through a click of a button. We also have the analytical dashboard that are able now to go deeper, dive deeper and compare how various regions are performing. I do aspect of also benchmarking here. They're able to benchmark trends within the FP visits, commodity distributed, and what surveys are saying. So they look at the 3 components, they're able to identify, is the growth or changes in service statistics being reflected in what a survey are saying? Are they saying different story or the same story? Or the trends within commodities being dispensed and user visits, is he saying the same trend? So you're able to see that. And of course, the data quality review, as I mentioned, utilizing on key quality metrics for data. That is, have the report come in? Are they timely? So are they complete all the reports sent? Are they timely? And also, is there internal consistency? And we're able to also correlate for the cases of lax. So that's IUD and also implants. Even injectables that you expect per visit you get 1 commodity. So able to correlate that and identify issues of quality. So in terms of user utilization for this solution, what I have here is for various case countries, and you're able to see how they have been using. So we picked time period for January to September this year to just see how various users have been interacting with this solution. And we saw that, for instance, in Kenya, within that, we anticipated that maybe summer dashboard could be the most utilized because you go at a click of a button, you have a presentation on family planning indicators, but you realize that people are really working on their service statistics data quality. And you can see that's why you have more users, the green one representing data quality review. Like in Kenya, even in DRC, Zimbabwe, and India, you can see they really focus within this period interacting with data quality review. So generating data quality score to see how various regions are performing and also correcting to ensure that they're utilizing the right data for decision making at all levels. And then followed, of course, closely by the summary dashboard, then in analytical dashboard where they're able to generate their custom-based graphs, and also the other report template which is already has predefined reports. So I will then just try to show what has been the user experiences in detail for Kenya now that we saw more traffic on this dashboard or module. So for Kenya, what has really gone well that we're able to see more traffic or users is the sense that the application has been supported by the Ministry of Health. So engaging boards, the Family Health Department, Family Planning Program, and also the KHS2, who are responsible for managing the all solutions for the ministry, having this hosted within the HMS environment. We have also trained users at both the national and subnational levels. So more than 270 officers have been trained across 16 counties. We usually get feedback from these users and also robust technical support. So they're able to reach us in case they want issues of enhancement. They're suggesting maybe they prefer this component to be maybe updated, or they prefer this more. So we're always providing that support, even in terms of user access. We realize in some instances, not all people have DHS2 access, so we're able to do that. And also, of course, cooperation and active participation from the counties. In some cases, we had the county leadership even participating in this training and urging their team that going forward, they should look at the solution and address all the components of quality, and also when they're having family planning meetings, to utilize the data as an evidence in planning and setting resources. So a few of challenges you have experienced are delays in analytics. Sometimes systems are running analytics. So if you have delays in running analytics for a country where DHS2 is like successfully implemented in Africa, we see some gaps in some of the missing data. Of course, limited training and also poor connectivity for some marginalized and hard to reach areas. So in terms of benefits and use, what you have learned as this solution has really simplified and improved performance reporting, such that you are just able to go there at a click of a button and get a report on how you are doing. So this has been done when you are trying to generate midterm reports, when you're trying to generate any quantification reports or any performance on family planning data consumption or use. So also our partners have used the solution to improve quality of data in counties where they're supporting implementation on key family planning programs. And also it has created, I can say, a common language around metrics and performance at all level. People are able to discuss about same data using same language at all higher and lower level. So that one has been a key, that in all sessions they're able to talk about what is going on well and try to translate or identify issues that's affecting their performance using the same language, now that they have the solution within the HMAS. And lastly, in terms of at the service delivery point, we also have experiences or from these are the reproductive health coordinators, the pharmacists, those who are using it on daily basis. They talk about looking at discrepancies in their data. We have someone talking about being able to do support supervision I can say, of objective that are quality meetings or RDQs, even from their offices, they're able now to be focused, knowing that this facility has issues. I'll focus this one on reporting, this I'll focus on this and that. And also people are able to use it to set resources, and also in daily meetings for family planning, like when they are having their DWG meetings and any other meetings. So this is how the dashboard has been used in Kenya. And that's why you saw more traffic or more users across the key components, even comparing to other user countries that we have. Thank you.
Thank you very much, Daniel. It was a good presentation. So I think our last presenter is Andrea Novella, currently Headspace Social Business Unit's digital health initiative across Africa, Asia, and Latin America, including its FemTech division. Right. Yeah. She has over 15 years of experience working in a health and wellness and spearheading technology-enabled impact-driven innovation and initiatives in both the public and private sector. So she specializes in leveraging digital solutions to reach underserved consumers in emerging markets, and her work has been featured in case studies, conferences, and publications, mostly globally. The WHO recognition for innovation SRH delivery during COVID-19. She's passionate about increasing opportunities for equity for women and girls, and prior to PSR, worked with the University of Galileo in Guatemala to co-fund and develop economic empowerment project, an economic empowerment projects that supported women entrepreneurs in successfully financing and managing their micro enterprises. A Guatemala native, she's fluent in English, Spanish, and Italian, and holds a bachelor's from New York University and a graduate degree from MIT in Columbia. So we welcome you, Andrea.
Thank you, everyone, for your patience while we sort out this technical details. There we go. Perfect, thank you. Great, we are ready to roll. Good afternoon, everyone, and thank you for being here. I was so inspired yesterday by Dr. Natalia and this concept of creating a world of infinite possibilities for women and girls. And it's my hope that after today's session and presentations from all my incredible co-speakers, that you might leave here inspired by the opportunities that data has to deliver on that. I believe that the big promise of big data is that it can support us in achieving universal health coverage by giving us insights into unmet needs and desires of the people that we are serving. And through these insights, help us create stronger, more resilient health systems. So let me explain how. As we look towards more sustainable models of social impact, we are challenged to deliver on solutions that can also become financially self-reliant in the long term. And to this objective, PSI has created a social business unit, which finds ways to deliver on sustainable healthcare through income derived through a portfolio of high-quality, affordable health products and services. And in an ever-changing landscape of digitalization and globalization, one thing that enables us to be resilient is our North Star, a model that we refer to as the consumer as CEO. With this as our guiding principle, we ensure that no matter what, our decisions are driven by the end users of our healthcare solutions, including their families and healthcare providers. And this matters for both long-term sustainability and to ensure that we are delivering effective, equitable, and impactful sexual health interventions. To accomplish this, we need data and insights to ensure that we are co-creating with our consumers and making better, more informed decisions in the design, implementation, and adaptation of our family planning programming. With the explosion of digital uptake and the digitization of our programs, which has also been accelerated due to COVID-19, we have new tools and sources to gain relevant and timely data. And big data can provide us with insights that can better help to understand the barriers, desires, and gaps that exist around family planning and help inform more people-powered care. So what is big data? Big data refers to these massive complex data sets that are quickly generated and come from a variety of sources. And it could be structured, which includes something like a form you fill out in a survey, or unstructured, which could even be something like a TikTok video. Anytime we do anything online, watch something on Netflix, scroll through social media, we are generating massive quantities of data. If you are a smartphone user, you're generating about 40 exabytes of data. That's a really big number, and it's hard sometimes to wrap my mind around this, but to give context, just how much data that is. Consider that the World Economic Forum estimated that there would be more bytes of data in the digital universe than there are stars in the observable universe. So when we say big data, we really mean huge. So the private sector uses big data to optimize their operations, inform their marketing, and ultimately try to increase revenue. So we thought, what if we could apply these same principles to help inform our program design and ensure that we are delivering more responsive and effective family planning interventions? And so we're going to look at how PSI is doing this in one of our more mature digital markets, which is Latin America, as a case study to how we can make this a reality. A little bit of context before I go into the methodology. PSI Latin America has a very comprehensive omni-channel healthcare strategy that includes over 40 online channels in its digital ecosystem. So for this research, we triangulated data from various sources. One was aggregating native digital metrics through all of our own social media channels, which includes over 13 consumer-facing digital brands that has reached, in 2021, it reached over 27 million individuals on those 40 online channels across 7 countries. So we call that native, and let's imagine, just for simplicity's sake of the explanation today, that each of these platforms, whether it's a chatbot, a social media channel, a website, speaks its own language. It has its own data. And so what we wanted to do was aggregate all of that data. Each channel has its own in-house analytics system, but the challenge was how do we consolidate that? So we used a third-party software that enabled us to connect all of these native data systems and, in a way, translate them. We also combined that with a social listening software, which was also a third-party tool that uses a similar mechanism, and it also uses a Boolean configuration to be able to capture public conversation happening in the online space around certain keywords and topics. And then it uses machine learning to also aggregate and analyze that data and give us information that includes qualitative things such as sentiment or quantitative information such as number of authors or number of conversations happening. And that allows us to identify some trends and outliers in this space. And then lastly, we combine that with qualitative feedback loops from the various other systems that we have happening online. So that includes online surveys and programmatic insights that we got from qualitative interviews with our community managers and our cyber educators. Oh no. Drum roll, please. I am about to share what we learned from this methodology. There we go. So when we distilled the data from these sources, there were 4 themes that came up. The first one was, menstrual cramps suck, but we still want to get a period. Something that was interesting was that the absence of menstruation was perceived as something negative from our users in Latin America. But there was this collective complaint around the inconvenience or discomfort around menstrual cramps. We also found that most consumers prefer to talk about menstruation through private channels, reflecting persistent taboos and stigmas around this topic. And what's interesting about this data is that it does reflect finding from some more traditional research that we have done, but what it does is allow us to go deeper, because it gives us more nuance into targeted segments, such as young people or such as smaller countries in Central America that we were looking at. We also observed a growing interest around menstrual cups. So in response to this information, what we did was adjust our content matrix to include more menstrual health content, and eventually we expanded our programming to include a stronger menstrual health component. And we're also working with our youth health ambassadors to help address some of these stigma and misinformation surrounding sexual health, including menstruation, as part of our training curriculum. Secondly, we found that there were a lot of fears and feelings around fertility. We saw that fear around potential impact on future fertility or concerns around how quickly fertility would return were one of the big questions and concerns around contraceptive uptake and use. Again, data into these barriers helps us to go deeper and get analysis into markets that we don't necessarily have research in, though it does reflect some of the findings that we already know from research, both in these and other markets. And so the way that we adapted, again, was to adapt our content strategy to include fertility concerns. And here we see an example on the left-hand side of some content that actually went viral on TikTok. In less than 2 days, we had about 2 million views. And I think that what this speaks to is really how important it is to generate relevant and engaging educational content aligned to what consumers are interested in and driven by insights, and how informing our strategies through insights creates more meaningful engagement and reduce costs from our programs. Because we were able to reach 2 million people or 2 million engagements with 0 ads and demand generation. We also found insights into some gender norms and women particularly expressing that they are tired of bearing the burden of family planning. And we noticed that there was very little conversations happening, very few authors who were men in this space. So in response to this, what it tells us is the importance of having a gender transformative lens in our programming, and we built an additional modern masculinities model for our youth health ambassadors, as well as started generating more content that was aimed at connecting and driven at the conversations that men would also be engaging with. And the last category of what we learned was pleasure. One of the bigger mentioned barriers to the use of modern contraceptives that we're already probably familiar with was the concern that condom usage reduced sexual enjoyment and pleasure. But in addition to that, we also found that there were concerns around IUD and concerns whether the strings would be felt by the partner. And so here is an example of how we adapted some of our content to that, and we did it in a humorous and relevant way. On the right-hand side, you'll see we show an example of an IUD insertion, and then we jokingly say, don't worry, nobody but your healthcare provider is going to be able to get that far deep to address that concern about the strings. So to recap, I guess what is most interesting about these findings is how it's reflecting a lot of the data that we had obtained from more traditional research, pointing to the promise of big data as a novel but effective source for collection to support our program decision-making, design, and iteration. Especially as we're grappling with that need to have relevant, timely monitoring data outside of traditional systems, particularly in cases for crisis responses such as COVID. This type of methodology was extremely helpful because we did not have time, as Susan pointed earlier, to implement and respond with more traditional research methodologies. Programs that want to implement something like this, I think really we need to pay special attention around security and around data governance and ethics and consent with our consumers, especially in regions where family planning is still considered taboo. Data breaches could have important implications and consequences to our consumers. So we want to make sure that we are operating with this duty of care in our data management, ensuring that we are obtaining the right consent. And it's also important to note some of the limitations that exist around this type of methodology as well. It is great for driving marketing, informing marketing campaigns, communications, but when it comes to looking at long-term health outcomes or uptake, we still want to use our traditional systems and methodologies. And then there's, of course, issues around certain bias, especially on digital channels where there is a gender bias and more men than women have access to these channels. So out of some of our learnings, I just wanted to share kind of where we're going next. So using the learnings that we have from our programs globally, including from big data and other novel data sources, we created VIA, which is PSI's femtech, and a solution to the fragmentation that we saw happening in our markets, where SRH solutions are siloed and a lot of touch points make the consumer journey a consumer odyssey. What VIA does is build on PSI's existing offering and expands it to a comprehensive, digitally enabled platform that brings together information, products, and services. What we want to do is harness the power of technology to equip women and girls and men to choose and own their health journeys. It is our belief that VIA will have a significant impact, not just in how we engage with our consumers, but over time, the nature of healthcare delivery. If we stay true to this North Star of a consumer as CEO, we can envision a state where we begin every management meeting, every product service exploration, every partnership discussion, every funding opportunity by asking ourselves, what are the insights telling us? What are we learning now, and what are we being asked for that we aren't currently delivering, so that we can truly deliver on people-powered healthcare. Thank you. And there's a QR code went down, but you can see me later. I have a QR code if you're interested in learning more about VIA.
Thank you. Thank you, Andrea. I think we only have 10 minutes, so I think I'll open the floor for questions and answers now. If you have any questions, please forward it. I'll give you a chance. 1, 2, 3. Okay, yeah.
Hello. I would like to ask a question about the big data. Are the technologies used open source, and are the data sets available online?
Testing, testing. That's a really great question. Right now, we are working, these are actually not open source technologies that we are licensing. However, we are looking at models that are more interoperable for the long term.
Sorry, let's all gather the questions and I'll give them time to reflect.
My question is about the Avenir, the Track 20 FP module. Can you estimate the cost of integrating that into DHIS2 from the countries that you've worked in?
Next question.
Hi, my question is to Ms. Ontiri. You talked about how working with nano-influencers creates demand generation for future audiences. Have you been able to actually, I guess, track the conversion, right, of people who actually go ahead to use the self-injection methods rather than just people who view the content? And then I think it's commendable that you had 60% of people engaged without them receiving any incentives, because I know nano-influencers do depend a lot on giveaways. What would you attribute that to? Because I don't think, someone will just fill a survey if there was not any other thing attracting them to it.
Thank you. I don't think we have any other questions. We have? Yeah, we don't. So I'll give each of you 2 minutes to address your questions.
Okay, thank you. I'll address the question in relation to cost. So basically, the initial cost was on coming up with the solution, of course. But after that, since it's hosted within the HMS environment, that's within the Ministry data centers, and so there's no cost in terms of hosting, but there's cost in terms of cost training, because we need to go to various regions to bring together reproductive health coordinators, health information managers, and also pharmacists for them to be trained. So that's the cost that you'll have to incur depending on the number of maybe regions you want to train or the number of cadres you want to train that. So that's within just one country setup.
Thank you, Daniel.
Thank you for your question. Our reflection on the response rate, I think it's about the choice of the nano-influencers, because the nano-influencers who we brought on board, before we actually identify them, we had done a scoping review of the existing nano-influencers and looked at those ones who really churn content, and they have huge followings. Not to the level of being a macro influencer, but there's a lot of audience engagement. And I think, again, this is very hypothetical, that because of the connections that they've been able to create with their followers, that could also explain the high response rate that we observed. When we set this out, we were working with around 30-40%, but we were also pleasantly surprised that we were able to achieve 60%, with some even going to, I talked about the fact that we had engaged around 40, some of them even had as high as 80%, while others had, I think the one who was listed was around 45%. thereabout, which was pretty impressive. The whole aspect of, again, that's a brilliant question about tracking. How we've set up our digital campaign system, it's basically an information provision channel. But we included, if you recall the chart that I showed, the slide on the ecosystem, where once a user is able to get this content online, they are connected with a chatbot to get that personalized care. We've tried to incorporate a monitoring component where we are able to actually follow up the users who indicated they wanted to be linked to a facility that provides self-injection services, noting that not all facilities have that capability. It's something that we are yet to track the actual figures, but the last time we checked, that was December last year, with a sample of around 2,000 women, only 44% had completed the entire user journey. But it's something that we'll keep on tracking in the subsequent months.
Thank you, Suzanne.
Thank you. And I can build off of my answer previously in terms of open source systems. So right now, as I mentioned, the data software that we're using is licensed. PSI is developing its own systems as well. And what we're looking at this point is working based on FHIR. So it's fast healthcare interoperability systems. It's quite a mouthful. So that we can start looking at potentially consolidating and aggregating the data with other systems, with other partners and whatnot. The raw data is not available, but I'm happy to share the insights, and we will be also sharing through our PSI blog publications. So stay tuned in that space for more information and dissemination of this content as well.
Maybe one question to also, because I said most course is training, but in some instance we had opportunities for co-funding for those partners implementing FP in various regions. So they say, we have this budget, we can have this solution implemented in this region. So of course we had more in terms of co-funding among various partners to have it delivered to users in the regions they're working.
Thank you. Thank you everyone for coming. And one last time, please thank our presenters for me. Thank you. And for yourselves also for being patient. Thank you.